our coordinator for
Hi.
this event live on Ortho TV. It has got around 10,000 orthopedic surgeon subscribers, I'm told. So there'll be more will be watching there. And also we have SESI members attending this webinar right now. You could see that in the attendance list. So we'll start. Sure.
I think you're muted, Ashok.
You see? Oh, he's the host now, Ashok.
But his mic is muted.
Yeah. Ashok, can we start?
We are online. We can go ahead, sir.
Okay, thank you. Good afternoon, everyone. Welcome to this Shoulder Elbow Society 6th webinar. We are utilizing the lockdown period for teaching purpose for the benefit of Shoulder Elbow Society members as well as the orthopedic surgeons in the country. So here we have exciting faculty and the exciting new topic to explore today. Without much ado, I will just start sharing my screen and then introduce.
Professor Bain, the keen box one was brilliant.
Oh, thank you. Thank you.
Okay, can you see my screen, please?
Yes.
Yes.
Okay, right. So a warm welcome from Shoulder Elbow Society of India. So as a disclaimer, which I would like to show, all rights reserved, all context, text, trademark, photos, graphics, file, design, arrangement used in this webinar are protected without the explicit permission of Shoulder Elbow Society India and the concerned faculty. It is prohibited to integrate in whole or in part in any of the content published here into other programs or to use them by any other means. This is a scientific session. This is actually streamed live in Ortho TV, but I would like to stress that this is aimed, restricted to healthcare personnel only. By attending the event, the participant confirms that his participation is in compliance with applicable professional code. So, why we have taken elbow joint today? Elbow is a complex hinge joint. It is not like knee joint. It's different, special. It is an important link connecting shoulder and the hand. The purpose of the elbow joint is to keep the hand in optimum position in space so that you could use it for every day-to-day purpose, recreation, sports. It's got two plane of movement, flexion, extension, and pronation, supination. Loss of 50% of elbow function is equal to loss of 80% of the whole upper extremity global function. Elbow joint should be painless, stable, and fully mobile. But please note the functional arc is around 100 degrees of flexion from 30 to 130. You don't need the full extension. You might not need the full flexion for day-to-day purpose, but 100 degrees of prosupination is necessary. So this is the functional range. So elbow joint is generally neglected in day-to-day practice as well as general orthopedic surgeons practice. Shoulder elbow surgeons usually do more shoulder, less elbow. Hand surgeons do more hands, less elbow. And it is also done by sports surgeons and trauma surgeons, but with varying level of significance and attention. So we would like to highlight the role of elbow arthroscopy, its current level, its application, and its future. We have an exciting faculty dedicated their service to elbow here today to teach you. So we have none other than Professor Gregory Bain from Australia. He's a hand and upper limb surgeon. He's a deputy editor of Journal of Wrist Surgery, president of Asia Pacific Wrist Association, chairman of Elbow Wrist Hand Committee of ISACOS, board member of Journal of ISACOS, and also board member of Techniques in Hand and Upper Limb Surgery. He has published widely on shoulder, elbow, wrist, hand. If you click his CV in his website, it will show only 75 pages. That much of publication has been done. Second, I introduce Mr. Joydeep Fadnis from Brighton, Sussex, as a shoulder elbow specialist. He had his training in New Zealand, Australia, Brightington, and he's got a keen academic research interest. The connection to me is that he was my registrar, my postgraduate, if you call as like India, in around 10 years ago. And this is an occasion where he helped organizing Epsom Ale combined advanced wrist arthroscopy and life surgery 10 years ago, which happened in Epsom St. Helier Hospital. And it was a good time learning wrist skills at the time. Now, after that, I had a great experience from learning elbow from none other than Sean Driscoll at Mayo Clinic. So I always had a keen interest in elbow. And therefore, in last year, we arranged a combined elbow conclave meeting at Chennai with collaboration with the best British Elbow Shoulder Society. And I invited Joydeep back to here. We have Professor Adam Watts from Wrightington, UK. He's the research and governance lead for the upper limb unit at Wrightington Hospital, co-convener of the Wrightington Elbow Symposium. He had his fellowship training in Adelaide, Australia, Wrightington, and specialist training surgery in Glasgow. The research areas include elbow replacement, elbow instability, and also forearm trauma reconstruction. He's a visiting professor at Manchester University. Thanks, Adam, for coming over here. Now, we have me, you can't escape from me, and also Deepthinandan Adla from Hyderabad to join the panel. So the program is set like this. First, opening batsman will be Deepthinandan Adla, Deepthinandan Reddy. He will be talking about the indication, the setup, the portals. It is very important to know the surface anatomy, the anatomy of the nerves, the positioning, a lot of tips and techniques to do the elbow arthroscopy safely. Followed by Professor Adam Watts talking about arthroscopy in sports injuries and OCD. Then we have Professor Greg Bain talking about endoscopic cubital tunnel release. It's a new technique in innovation by Professor Greg Bain. He will talk about when to do and how to do. Joydeep Fadnis is going to talk about arthroscopic OCA. This is osteocapsular arthroplasty, well popularized by Sean Driscoll for arthritic elbow. Then I will talk about the role of arthroscopy in post-traumatic stiff elbow. We have biggest problem in India is the stiff elbow. So we will focus more attention to that. We're supposed to talk about the stiff elbow release, but already two topics have been discussed. Professor Greg Bain is going to talk about the future of elbow arthroscopy. He's going to talk about new ventures and new techniques. And finally, he will close the program with talking about complications and safety standard. It is very important. Elbow arthroscopy does carry a small complication rate with nerve injury. So, and also many other small problems which you have to maintain safety. So with that words, let me just stop sharing. And thanks, Nandan, for starting your talk. You can please.
Yeah, thanks a lot, Ram, for organizing this webinar. It's good to see Adam. I think we met in Leicester recently, the Leicester Elbow meeting. I basically trained in India and then in UK. I did my upper limb fellowship in Sheffield with David Stanley and did my elbow arthroscopy with Sean O'Driscoll. I was on the best fellowship to Mayo Clinic. I'm just going to start with simple indications and some basic outcomes of various procedures after elbow arthroscopy. Now, elbow arthroscopy, if you look at it historically, it was attempted in 1931, and it was felt at that point that it is too small a joint to be examined and too small a space to be scoped. But later on, it's been evolved. We have got new techniques. People like Dr. Watanabe and Dr. Andrews, and later on, currently, Dr. O'Driscoll and Dr. Cohen have popularized these arthroscopy of the elbow, and now it's become almost a routine practice in orthopedics.
Yes. Yes, Nandan. 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 Ashok.
Hello, sir.
Yes, can you hear Nandan? Voice is not here.
We can hear you, sir.
I can't hear. Okay.
Can you hear us, sir?
Yes, I can. I cannot hear Nandan's voice. Is that everyone is hearing?
I can't.
No, we
hear
can't hear his voice.
Yes, it's only the slide there. Is Nandan here? Have some problem in connection?
I think his screen's frozen.
He comes.
You might have to reconnect, I think.
Okay. Give him a call. Wi-Fi went off. So what do you want to do? Move the next one?
I can give my talk if you like.
Yes, yes, yes. Okay, okay, yes, please. I think there's some problem with the Wi-Fi connection for Nandan, so he got disconnected. Okay, we ask Joydeep to. You ready, Joydeep?
Adam, do you want to do your talk next in the order of the?
Yeah. Yeah. So is that working?
Yes, please. Yes, Adam. Thank you.
Okay, so I hope everyone can hear me okay. Ram and the Society, many thanks for the opportunity to speak to you today. I have no disclosures for this topic. I have worked with a number of clubs and teams and institutions in the UK in sports, but I have no financial conflicts or anything to declare for this topic. When we think about trauma in sports, we can think about either acute traumatic or chronic overuse injuries, or what is probably more common in our practice in the UK is the acute on chronic injury. We have obviously a lot of contact sports in the UK. Now, this may not be completely relevant to your practice in India, but these cases do arise in all practices. So rugby is a big generator of work for us, but so too are things like boxing, where we can get acute on chronic problems where they develop impingement lesions within the elbow from forced flexion and extension of the elbow. They can generate loose bodies within the joint, and they get internal impingement, so pain in deep flexion, pain in full extension of the elbow. And that's because these osteophytes forming in the floor of the fossa. You can see loose bodies here and osteophytes in the back as well. The use of 4D CT scan can be helpful to help us to understand where the impingement lesions are occurring and to help us to plan the arthroscopic debridement. And removal of loose bodies is a straightforward procedure and a good starting procedure, even if the video doesn't work, for relieving symptoms of locking and jamming of the elbow. And it's often the loose bodies that cause the acute flare-ups within the joint. But while you're there, also worthwhile removing any impingement lesions that are present. And what you often find in these athletes is that they have very healthy articular cartilage, but they have osteophytes, periarticular osteophytes, that are relatively straightforward to remove, both posteriorly and anteriorly. And often you can just see in the bottom right-hand corner of the screen, a large coronoid osteophyte as well that needs to be removed. Acute injuries are obviously pretty dramatic and can present in a variety of ways. I haven't got time in this talk to go through the arthroscopic treatment of fractures, but we'll talk a little bit about soft tissue injuries around the elbow. When somebody dislocates their elbow like this, the vast majority are going to be posterolateral dislocations, about 80%. And we've shown in a consecutive MRI study that the majority of these, the injury starts on the medial side and extends laterally, and you can grade the level of injury. For that sort of dislocation, I would normally perform an open surgical stabilization if they require any surgery. But as O'Driscoll has pointed out, there are cases in which rather than having a valgus hyperextension injury, they have a supination injury on a flexed forearm, which leads to injury to the lateral ligament complex. And those patients sustain a posteromedial dislocation, so a much more rare injury. But the injury is largely to the lateral side of the elbow, and they may have intact medial structures. When we're considering these patients, we need to understand the structures on the lateral side of the elbow, because actually there are two types of posterolateral rotatory instability that can be encountered following an injury to the lateral ligament complex. We've recently talked about the importance of this posterolateral ligament in the elbow, what leads essentially to an Osborne cotral lesion, where you get this bony avulsion from the back of the capitellum. And we need to reconsider this when considering the anatomy on the lateral aspect. We've shown that you can have a stepwise increase in posterior instability of the radial head by sectioning that posterolateral ligament compared to when the lateral ligament is intact. And that gives us these two types of posterolateral rotatory instability. Those with a positive posterior draw but a negative pivot shift test, in whom the LUCL is intact, but the posterolateral ligament is torn, and the type 2, where they've got a positive posterior draw, positive pivot shift test, and they've torn the LUCL and possibly the posterolateral ligament. So this is a type 1. So you can see on this MRI scan, the lateral ligament complex is completely intact, but there's a sleeve avulsion of the capsule from the back of the capitellum. When we scope this elbow and supinate the forearm, you get some opening on the lateral side, but not as much as you would see with a lateral ligament tear. When we stick the scope in the lateral compartment, you see that bare area just proximal to the articular cartilage. And when I look at this one has a partial radial head fracture as well. But when I do a posterior draw, the radial head subluxates dorsally. So this is a patient with an intact lateral ligament complex, but a torn posterior capsule. And arthroscopically, it is possible to repair that. Here, I've done it through a mini arthrotomy because it's just easier to demonstrate. But it's perfectly feasible to put an anchor into that area and then repair the capsule back to that bare posterior capitellum. You just using an anchor, and I prefer to use a juggernaut anchor for that. In the chronic situation, you obviously get articular damage and fraying of the articular surface. But again, a positive posterior draw, but a negative pivot shift test. And those patients, it's not possible to repair, but we can do a reefing. And Roger Van Riet has described a nice technique that I haven't got time to go through in detail here, but we can arthroscopically reef the lateral posterolateral capsule, and that normally will restore stability in these patients. For the PLRI type 2, so this is a more extensive injury where the lateral ligament complex is avulsed, then you'll see gapping on fluoroscopy, and they'll have a positive pivot shift test, as you can see here. with the radial head subluxating dorsally, as Sean O'Driscoll has described us, has taught us. And when we look in the front of the joint, so you can see the radial head and capitellum, and you see this sleeve avulsion of the lateral ligament complex. It looks a bit like a rotator cuff tear, I suppose, looking from inside. And we can repair those arthroscopically. Here I'm using a Scorpion device brought in through an accessory lateral portal and passing some sutures through the lateral ligament complex, viewing from the front. Often using a 70-degree scope it helps you to see around the corner when doing this. And as I pull on those sutures that have been loaded, you can see how the radial head now reduces up against the capitellum. And I use fluoroscopy to make sure that my anchor is placed in the correct anatomical center of rotation to restore stability to the elbow. The injury that probably is more you're more used to addressing in India is the problems with the medial side of the elbow and the valgus extension overload injury, which is a chronic injury to the medial collateral ligament. And you can see this fairly classic T sign here, showing that the medial ligament has been elevated from the sublime tubercle.